There is still huge variations in quality in general practice. There are some people who are managing chronic diseases brilliantly. There are some people who are pretty much supervising a premature death on a massive scale by supervising heart disease and diabetes and stuff really badly. And that variation in quality is huge, and we haven't quite cracked it yet. And people need help with that. They're not doing it deliberately, but they're stressed and they're slightly out of control, and they need help. So I would fundamentally do the quality improvement stuff. And I think my history of particularly the poor side of general practice is it is often the phlebotomist, the receptionist, the nurses, the practice manager who picks up the trouble, picks up the problems, but because they're employed by the GP, it's often quite difficult for them to raise concerns. So when we had a National Patient Safety Agency, or I think it's probably has it been decommissioned yet? It's gone. We used to have this to try and learn from significant events, which is really important. There was a significant event reporting system where everyone was encouraged anonymously to report their mistakes that they made and their near misses, so we could analyze them, we could learn from them. So of all the reports that came in, and many thousands came in, how many do you think came from general practice? Less than 1%. So 80% of the care goes on in the community, less than 1% of the reports came from general practice. Do you know who did most of those? Nurses in immunization clinics. Slightly worried they might have given the wrong dose. So it was only nurses reporting. GPs do have significant event audits, and we sit round in a room and we share bad practice. And if someone's made a big cock-up, we go, whoa, let's just hide that. We're not going to report that. We do close it. We do try to change our practice, but we've always traditionally been very reluctant to take it outside the practice. That is probably going to change. I think what will happen in future is that GPs will have to work in larger federated groups, and they'll have to share their data. So you will know within your group who's struggling to manage diabetic patients better. And I think that's actually quite a good thing. I think that's what professional self-regulation should be all about. I have to say it's a bit... I don't know about the quality of care I deliver as a GP, and it worries me slightly, because in the old days, there was no quality control in general practice. People popped into the GP because it was on the way to the supermarket and they fancied a hug. That was basically it. You'd hold hands, you'd do a bit of therapeutic gossip, you'd send them on their way. And if they didn't come back, you never knew if you'd killed them, whether you'd cured them, whether they quit in disgust. You know, as long as they didn't come back, that was the only outcome measure we had. And then sometime, probably the Shipman inquiry triggered this. The government decided that all GPs were potential mass murderers. And they had to control us more. So they introduced this thing called the Quality and Outcomes Framework, which was also about managing chronic diseases better. Not necessarily a bad thing. It was trying to get evidence-based medicine into practice. So GPs were incentivized to treat diabetics and people with high blood pressure and high cholesterol in a better way. Of course, one of the side effects of that is that GPs tended to concentrate on the patients that had incentives attached to them. So if you have diabetes, high blood pressure, high cholesterol, I'll give you lots of time because I get lots of money from you. If I treat 5 patients like you, I can send both my kids to public school. But if you have epilepsy and dementia and incontinence that aren't attracting any brownie points, I might give you less attention. So already it makes it slightly, you know. And the other side effect from this is that GPs spend their entire time now staring at a computer screen. You know, the principle of all healthcare is the humanity, the eye contact, the getting the patient's name right, the looking at them in the eye when they come in. And we're not now. We're staring at the computer all the time because we have to fill in all these little graphs to tick the brownie points. It's happened to nurses as well. If you sit in with a nursing clinic, it used to be all about therapeutic gossip. Now the nurse is staring at her computer all the time, filling all these things in, trying to be holistic while serving the computer. I did it the other day. I'm quite a good communicator, but I was filling in the previous patient and staring at my computer. And this old lady came in. She was obviously a bit pissed off I didn't give her any eye contact. And she came up behind the screen and she went, beep-boo, like that. Which I think is actually quite a good game to play with your GP.